My next two guests are experts in diabetes management, health disparities, and the connection between diabetes and obesity. Dr. Felicia Hill-Briggs is Vice President of Prevention at Northwell Health. She's a clinical psychologist and behavioral scientist. Her expertise lies in designing individual-level and systems-level interventions to improve prevention and management of diabetes. And Dr. Scott Kahan is the director of the National Center for Weight and Wellness and is a physician trained in both medicine and public health. He's advised several surgeon generals as well, and members of Congress, governmental agencies on obesity, nutrition, and chronic disease prevention. He's a cool dude. I have enjoyed conversations with both of my guests. Look, let me just start here, Felicia, with a question. I always like to talk with knowledgeable, thoughtful people here. What are the dimensions of this we haven't talked about so far? What are the blind spots in our conversation about understanding how to deliver better health in this country more evenly? What are we missing in our conversation? Educate us.
Yes. Well, I think I agree with Dr. Gabay, who said he's very hopeful and sees reason to hope for where we're headed. I would agree. I'd say one of the largest gaps has been and continues to be, of course, how we achieve equity in care. So, as we all know, we have tremendous opportunities with all of our therapeutic innovations, with the data availability, algorithms, machine learning technologies. There are tremendous opportunities to improve diabetes outcomes. However, in each era of innovation, we have seen the persistent pattern that racial and ethnic minorities and people with lower socioeconomic status are not faring as well due to many factors. Access factors, due to what now we're calling social determinants of health. And until we can wrap our heads and our initiatives around this huge phenomenon of social determinants of health, it's going to be very difficult for us to see population-level improvements in diabetes care.
Wow. Scott, we have talked about this as well, that sometimes the messaging that we've been sending out to people about what they themselves can do in terms of becoming more empowered in this has been out of kilter. And I would love, in your work as well, to ask that same question I just asked Felicia, which is the question of what are our blind spots? What are the opportunities? What's the low-hanging fruit out there we may not even be thinking of in terms of addressing, again, coming back to the patient who's trying to struggle through all this? What could we be suggesting as part of the package?
Yeah, first of all, I'll say we don't have to look for things that we haven't even been thinking of. We already know a whole lot about this. There's a lot of very good research showing that there's so much that we could do already with the knowledge we have already, with the counseling techniques we have already, with the medications we have already, and even more coming on the line. So one of the things that unfortunately tends to happen is whether doctors talking to patients or whether broader advertisements and communications around behavioral change and eating healthy and weight management, it tends to be nagging often rather than supportive, thoughtful, productive information and support to help people make some changes in their lives. Another of the unfortunate counterproductive messages that can occur is that people have to lose all their weight in order to be healthy and in order to prevent diabetes. They have to get thin or the like. The data we have is very, very different. You lose literally 5, 10, or 15 pounds. And that tends to improve health, it tends to improve quality of life and mobility, and it significantly decreases the risk of getting diabetes if you don't already have it. And if you have diabetes, it already starts to improve it quite a bit. For those people that may not get enough benefit from nutrition and exercise changes and losing some weight, there are medications that are very helpful, both medications that are helpful for diabetes treatment, as well as very good medications that are FDA approved to treat obesity and that have been shown to significantly reduce the risk of getting diabetes by 70 or 80% in some cases. If you're at risk, and also improve diabetes when you have it. So lots that are out there. Unfortunately, we're just not using them as much. We're not getting the word out. Only 2% of people who have an indication for an obesity medication actually use those medications. Same thing with bariatric surgery for people with very severe obesity. Only 1% who are eligible get bariatric surgery. Very few people who are eligible for counseling, basic counseling from their doctor on weight management and prevention. Only about 1% get that counseling. So we need to do a better job of putting what we know into place, even more so than getting new technologies and new options.
So, Scott, what is, let me just give you a quick minute. You talk to Surgeons General, and you talk to a lot of people in this. Why haven't we made that progress in messaging?
Look, there's certainly a lot of reasons. One is some of the people that often would be the figureheads in the messaging, physicians and other healthcare providers, rarely get any training in weight management, in nutrition, in behavioral change. When I was in medical school, just a touch over 2 decades ago, there was nothing. I had an hour lecture on nutrition and weight management, and that was very, very basic. Today, it's not that much better. And I will say, unfortunately, he didn't bring it up, but Rep. Burgess, who you had before, he has co-sponsored a resolution that would increase the importance and hopefully the availability of training in medical school and other health professional training programs around nutrition and prevention and weight management. So that's one of the important reasons. I think another big reason is weight stigma and bias. There are lots of prejudices in our culture, but one of the most prevalent is around people's weight and appearance. And so it tends to lead to doctors either not bringing up weight in the medical office, or often sort of finger wagging and stigmatizing patients about it. It is part of the reason that policymakers tend not to focus on areas of nutrition and obesity and weight management because they often believe that patients just need to, suck it up and be healthy and eat less and exercise more. And it's often, believe it or not, self-directed stigma is also very common. So people who have obesity and diabetes often are so ashamed about it that they don't reach out for help and don't take advantage of some of the opportunities and resources that are available to them. So for those reasons and others, I think that's how I would answer your question.
I appreciate that. Dr. Hill-Briggs, I know this is going to sound like a non sequitur, but folks, it is not. I used to, and I still do, a lot of trade policy, commentary and work. And years ago, decades ago, America wasn't running a trade surplus with Korea. We were kind of in a deficit, and we used to talk about it forever. That was Japan. Now China's is huge, et cetera. But eventually that Korea-U.S. trade deficit corrected. It was a change. I want so much the issue of health equity to be like that we actually talking about, if we talk about COVID and the impact on communities of color in this country being disproportionate with, say, the white community in this country, is a topic I really wish would go away because we achieve different results. And so I'm wondering, are there any models out there? Did we learn anything from COVID, with the tens of billions of dollars spent on, finding trusted ambassadors, trying to find different ways to communicate, going into communities, more differently, whether there's anything there that we can learn from that succeeded, or is this such an endemic problem? And I have to just be honest with people. There's a trust problem between a lot of the health community and certain communities in this country. So I'm just interested in your insights on what we can do to reverse this so we can come back and begin applauding, achievement in health equity.
Yes. So, Steve, I think what's probably most important for all of us to understand is how complex the issue is, how deeply entrenched the issue is, and that it's not a transient or temporary problem.
Right.
There was a point in time during which physicians would see a patient who's homeless or a patient who is food insecure or having difficulty during that visit with paying for their medications. And the physician was mobilized to try to find some social services to help that individual. What we now know, although I don't know if we are fully grasping the severity of this, but what we now know is that these social determinants of health are historical in nature, they are cyclical, they are intergenerational, and they are population-based as opposed to individually based. And so right now, our focus has still been a great deal on what can we do for each individual. Let's measure needs of each individual. Let's see what we can do to connect each individual to a set of resources or social services. That is not going to get us all the way where we need to go. These solutions are going to be more complex. Some of the recommendations that we really need to take heed of are really ones that originated with the World Health Organization, who was the first to establish a Commission on Social Determinants of Health, and in 2008 and 2010 put out recommendations that really address the fact that social determinants are systemic in nature. It's about the conditions under which people are born, grow, work, live, and age. And those conditions are influenced by economic structures, political structures. And so in order to address these, both internationally and here within the United States, we have to think bigger than what the healthcare provider can do, and even bigger than what the healthcare system can do. Health in all policies is one approach that promises to bring us closer to what we're striving for by way of equity. And that is that health has to be a part of all decision-making at a policy level. It has to be a part of decision-making in all sectors. In the housing sector, for example, if housing developments are being built or housing units, there needs to be a source of food accessible to the people who will live in those housing developments. When decisions are made about things such as waste or pollution, health has to be a part of those determinations. We don't want inadvertently to continue disadvantaging low-income neighborhoods or rural areas in having to deal with environmental decision-making and the health impacts of those environmental decisions, for example. So health in all policies is an approach that is being recommended by the American Public Health Association. This is an approach being used internationally, and we need to bring together the sectors and stakeholders to do serious planning beyond only what a healthcare practitioner can do with a given patient on a given day.
That's a very comprehensive answer, so thank you for that. Scott, the other dimension of this, which I know you deal with in your regular practice, are the connections between obesity and diabetes. Should we be finding a way from a practitioner's perspective, or looking at how we treat and look at it, what the playbook is, of pouring a lot more resources and effort on the front line of those initial diagnoses than we are today? And that includes paying for it, which I know we don't.
So, without question, the broader way of looking at it is we need to move upstream. So rather than just treating diabetes, if we move upstream of that and help people with healthy nutrition, physical activity, and weight management, that significantly decreases the burden of diabetes. And as Felicia was saying, if we move even further upstream from that and help set the stage for healthier living, that will significantly improve the likelihood of people being able to manage weight, eat healthier, live healthier lives, and ultimately improve and reduce diabetes risk. Specifically with respect to obesity treatment, there's so much support for what we can do to improve diabetes by treating and addressing obesity. Good counseling, we heard earlier, the diabetes prevention program, with modest behavioral changes and very small weight losses, we cut the risk of diabetes by 60% in people who have obesity and prediabetes. The medications that we have, FDA-approved medications for obesity now, they cut the risk of developing diabetes for people at risk by 70 or 80% for some of them, as well as other positive outcomes. And bariatric surgery, especially in patients with diabetes, has been shown to be incredibly helpful, not only in weight loss and blood sugar improvement, diabetes improvement, but also in long-term mortality, not dying young. So if we can better address obesity, there's going to be a whole lot of benefits, including with respect to diabetes. Again, a lot of this has to do with broader factors than just what's happening in the clinic. So there's little training of providers, particularly the primary care workforce in obesity management. There's very poor coverage of evidence-based obesity treatments. And the stigma that surrounds it all is another broad societal factor that tends to get in the way of all of this.
I mean, it's a huge thing. We have a question from the audience from the two of you. Let me ask Richard Bailey. Richard?
Hi there. My name's Richard Bailey, and I am an MD, MPH candidate at Case Western Reserve University. My question for the panel is, how is continuous glucose monitoring technology addressing barriers to implementation, and how can this technology be distributed more equitably? Thank you so much for your time.
What a great question, Richard. And I also love the energy. So great. Thank you. Felicia, your thoughts?
Well, continuous glucose monitoring, without question, has been a game changer. Whether you're doing research on outcomes and the impact of time in range and the impact on people with diabetes, feelings of empowerment, understanding of their diabetes, understanding of the relationship between their behavior and their blood glucose levels, CGMs have provided the type of information and the type of autonomy that people with diabetes seek in order to make better decisions.
Felicia, if I can interrupt just for a moment, would you do our audience a favor? Because we have a lot of lay people watching this, and they may not know about continuous glucose monitoring as a device, how it's different with it. Can you just tell our audience a little bit about it, and then how it differs from what pre-existed?
Yes. So continuous glucose monitoring is a way for people to self-monitor their levels of blood sugar. And so traditionally, people would monitor their blood sugar at home using a device wherein they prick their finger, they'd get a drop of blood, they put that drop of blood in the meter, and that meter reads what the blood sugar level is. Continuous glucose monitoring is a system that enables subcutaneous sensor, a sensor that's under the skin that reads blood sugar levels on a continuous basis. And Scott, I may be mistaken, I think depending on the meter, it's about every 6 minutes
so a lot
or
less stabbing.
So a new reading appears. And so you do not have to do that stabbing of your finger, as you're saying, Steve. Instead, you're able to keep this sensor in your skin for a period of days to weeks. And again, it depends on what continuous glucose monitor you have, the number of days or the number of weeks it's able to stay in. And so what's different is that, we know that blood sugar levels change constantly. They can change while you're sitting still at a desk. They certainly change when you're eating or consuming something. They change when you're doing exercise. And when you have to monitor, when you have to stick your finger, people will only know what their blood sugar is at that moment in time. with the continuous glucose monitors, because it's not just a once a day or 4 times a day reading of your blood sugar, you're able to see patterns in how your blood sugar is responding to your activities across the full 24-hour period. That information has been extraordinarily useful for people with diabetes because it acts as biofeedback. You're able to get rather proximate or rather immediate feedback about what you're doing and how it's impacting your blood sugars. It takes, what you'll hear patients say is, it takes a lot of mystery out of blood sugar levels and how it got where it was. And people are able to test eating their favorite food and see how it affects their blood sugar, so that in the future they know how they may need to adjust their insulin if they're taking insulin, or need to adjust what they're eating or how they're eating, or foods that are really detrimental to them immediately. And so I think for all of us who are practitioners working in diabetes education and care, and for all patient advocates, we really do want to see continuous glucose monitoring available to all patients with diabetes, because of that ability to give the patient greater understanding and control over how they manage their disease. It's not only about making decisions about insulin, and it's not only about having their physicians look at their patterns. Those are very important, but at an immediate level, it allows patients to make better decisions on a daily basis and learn their bodies. And so we tend to see tremendous improvements in blood sugar management with CGMs.
That's very hopeful. Scott, I'm going to give you a chance for the wrap this up with us, but to respond both to Richard's good question, but also look at, are there things we can do to kind of improve equitable distribution? Are there things by way of metrics, by way of biofeedback, in which Felicia just talked about, that you would see as useful out there that we're not doing now? Give us your thoughts in response to Richard Bailey.
Well, in terms of continuous glucose monitoring, Felicia gave a great overview. The problem, as she alluded to at the end, is that it's difficult to get these covered for patients. I can't tell you how many of my patients would benefit from being able to use a CGM, and it's a tiny minority that are able to actually get it covered by insurance. If you don't have diabetes, there's no chance. If you have diabetes, often there's still little chance. You have to have diabetes, on insulin, and often on quite a lot of insulin, very poorly controlled diabetes, before they'll get covered. And they're expensive little machines, unfortunately. So again, here, this gets back to what I said at the very start, which is, look, we have a lot coming in the pipeline in terms of new technologies and new opportunities. But without even all of that, we know a lot. We have a lot of great resources already. We're just not using them as well as we could be. Some of that needs to be addressed by policy changes. Some of that needs to be addressed by better education of patients with diabetes. Some of it needs to be addressed by better education and knowledge of the doctors and healthcare providers that support their patients who have diabetes. So that's where we need to go, I think, in the most immediate term, and we'll build more from there.
Well, listen, thank you to you both. What a great primer. I'm going to go back and watch this myself just to relearn what you've shared. Dr. Felicia Hill-Briggs, Vice President of Prevention at Northwell Health, and Dr. Scott Kahan, Director of the National Center for Weight and Wellness. Thanks so much for joining me today, and I hope you'll come back soon. It's such an important topic, and really appreciated both of you kind of bringing your A game to this. Thank you.
Thank you.
Thank you.
Well, that brings us to the end of our program today. It's a very important topic. A big thank you to Eli Lilly for its support of these conversations, and to all of you who have attended. For anybody who missed this, we're going to have the video of this entire set of conversations on our website shortly. Go watch it, go share it. I'm Steve Clemons. Be well.